Hi, I'm Matt Williams. I'm a consultant oncologist based at Charing Cross Hospital in West London.
And I'm Shivani Soni, one of the senior CNSs.
So we've been asked to go over some of the common questions that patients and carers have been asking in the context of treating people with brain tumours during the COVID pandemic.
Was around kind of the anticipation of what we expect the next few weeks to look like as a result of coronavirus. And I think for us, we expect obviously those numbers to increase and the impact on the hospital and the NHS to increase. And looking specifically at Charing Cross and the service we deliver, we have 3 oncology consultants, 3 specialist nurses and 3 registrar level doctors. And I think fair to say that we're anticipating that within the next week, we'd expect that to now be down to 1 consultant and probably 1 specialist nurse to manage the service. So I think we, as I say, expect the numbers to increase kind of going forward, and our ability and capacity to be able to deliver the service we offer is going to be greatly reduced.
Yeah, so as a very practical example, I was in clinic this morning. I'm in clinic again on Thursday morning, but Friday and this weekend, because the junior doctors are being taken off the oncology ward, I'm then going to the ward to be the junior doctor on the ward. And so that means I'm then not available to do the neuro-oncology work. Now I'm sharing that with another consultant, so there will be one of us around for advice. But you can see that the COVID pandemic is going to have an impact. So one of the other questions we've been asked is about how we make these decisions. So I think it's worth trying to emphasise that there's a dual approach. So there is national guidance about how we approach this. So this isn't individual oncologists or individual surgeons going, oh, well, I'll do this and I'll do that. Certainly at Charing Cross, all of our decisions are made through the multidisciplinary team meeting, but they're also made in line with published written guidance. But at the same time, a lot of those decisions are individual. So if we talk about risks associated with treatment, then different people have different thresholds for risk. And so it's about trying to strike a balance between having a policy that's consistent and fair and applied across patients, which is also hopefully safe, while at the same time taking individual patient concerns into consideration. So I suppose, we've been having these conversations now for 2 weeks, I think.
Yeah.
What's your feeling about those conversations and patients and carers' views?
They are difficult discussions that we are having, and I think the majority of our patients understand where we're coming from, and I think everyone appreciates the difficult situation we're in as a result of coronavirus. But I think there are a handful, especially of our higher grade 4 tumours, where those difficult conversations are a lot harder, and some of our patients and carers have felt like we're giving up on them and kind of they're not worth the NHS resources and time, which obviously isn't the case, but you can kind of see it from their perspective.
Yeah, and I think you and I have talked about this, about trying to make sure that patients and carers don't feel abandoned. I'd certainly, from my point of view, my big worry about giving chemotherapy, particularly to older patients, is the risk. And we'll be clear, the risk that we end up giving chemotherapy and people end up dying as a result of that. And that's obviously something that we want to avoid. But I can also see that stopping chemotherapy can also feel like a big step.
Yeah.
And I think for me, it's about trying to balance the risk.
Yeah. I think fair to say that actually a lot of our patients have been reassured by their symptoms being a good indication equally of kind of what's happening. Because I think a lot of our patients, and even as healthcare professionals, we get quite tunnel visioned on needing MRI scans to tell us what's happening. And I think key to remember that actually that's only half of the picture, and the other half is actually clinically how someone is and what their symptoms are like. And a lot of the patients I've spoken to have been reassured if I've said, well, actually, if you're symptomatically quite well, it's a high chance that actually your scan would equally be quite well, and then to touch base with us if things change, and having that kind of safety net for them has been quite good.
Yeah, and I'd agree, and I think it is worth remembering that most patients, certainly with high-grade tumours who develop progressive disease, will tend to have symptoms. And so our ability to scan people has obviously been significantly impacted by COVID. And so for patients who are well, actually I don't feel a great urgency to jump into scanning because it's likely to show that everything's okay. And I think that then allows us to reserve our scan capacity for people where we are concerned that things might be getting worse, and then we still do have some capacity to scan people and see what's going on.